Bob Challoner, the President and CEO of Southampton Hospital, and I'd like to welcome you to another edition of Focus on Southampton Hospital, our monthly program about the goings-on at your community hospital. Today we have a very interesting and a little different program, and I'd like to welcome Denise Reilly, who is the Executive Director of eHealth of Long Island, eHealth Network of Long Island, which is something called a RIO, Regional Health Information Organization. So welcome, Denise. Nice to have you on the program.
Thank you, Bob.
Let's start at the beginning. RIO, and electronic healthcare, electronic medical record keeping. What exactly is a RIO?
So a Regional Health Information Organization is a way for a patient's information to be shared amongst healthcare providers. I like to explain it as we're the pipes between healthcare organizations, so that as a patient moves from one organization to another, their healthcare information goes with them.
Any kind of patient information, or?
Providers usually decide what information is most pertinent to have about a patient. So for example, allergy information would be very important to have, medications that a patient takes that would help a provider make good clinical decisions about a patient's care.
And who can participate in this? Which patients can participate in it?
All patients can participate, and all providers could participate in it.
Okay, and is it only, which organizations out here on Long Island are participating?
So we have our flagship hospitals of Southampton Hospital.
I had to make sure we got that in there about us being a flagship, right?
Stony Brook University Medical Center,
Right.
Peconic Bay, Eastern Long Island are our hospitals that are associated with us. We have several nursing homes like San Simeon by the Sound, Long Island State Veterans Home. The list keeps growing, so you can go to our website to see the most up-to-date list. But
Okay, great.
Quite
And
a few.
that website is?
eHealthNetworkLI.org.
Okay, I know they'll show that on the screen for us also,
Great.
probably as we're speaking. Let's talk a little bit of history. I know that traditionally patient would come to the hospital and lots and lots of record keeping was kept on every patient encounter at a hospital or a doctor's office. Somebody once told me that medicine is all about keeping good information about people. And traditionally we wrote all that stuff onto paper records, the medical record. Over time we computerized some of it. This is really the next evolution, right, of the medical record and its attempt to create an electronic record.
Yes. The recent Healthcare Reform Act came out to say that if we had our information electronically, it would save patients' lives. We would make less medical errors. We would be able to cut down on costs, prevent duplication of testing. And what I like to think is the most important thing is it helps the patient so that they don't have to get copies of their records and bring it from one place to another, which can be quite cumbersome and costly to them.
Right.
With the RIO and the eHealth Network of Long Island, the information is available to the providers. So as the patient goes for a second or third opinion, or goes to the city for information, or tries a new provider out, or has several comorbidities, has diabetes, cardiology that they see, this will allow them to have that information available at whoever takes care of them.
So historically, I mean, something that I've been asked is people are often surprised. They go see my doctor, then I go to the hospital, and the hospital doesn't necessarily know what went on in the doctor's office. This is really an attempt to create that bridge, right?
Exactly. It is surprising how many people think this already exists,
Right.
and are surprised that it is not there. But we are moving towards that, because it is the patient's healthcare information, and you want to make sure that a provider can make a well-informed decision about a patient's care to make sure that they're on the road to recovery.
And this is happening, this development of this electronic really superhighway is really something that's part of a national effort, correct?
Correct. There are 10 other regional health information organizations in the state of New York. We're working collaboratively with them to share that information among the 10 RIOs. So as a patient moves throughout the state of New York, their information will be available. That superhighway is called the SHINY, the State Health Information Network of New York.
Which is organized by the state, or?
It's by an organization called the New York eHealth Collaborative,
Okay.
also another acronym called NICE.
Right.
We are hopeful that by the end of next year, we will have all of the providers in the state of New York connected electronically.
So at this point, it's a regional effort on our part.
Yes.
We've now joined the larger statewide effort,
Yes.
and the goal is to have all of those networks talk to each other.
Absolutely.
So anywhere, if I'm hospitalized here on Long Island and for some reason I'm traveling up to Buffalo, they'll be able to see my records. That's the goal.
Absolutely. College students, this is a huge benefit for us. So their medical information is available to them if they go to state colleges in the state of New York as well.
Any attempt to share records outside of New York at this point?
Right now, the states have different consent laws from state to state. In New York, you have to consent to be in the system. We call it as an opt-in state. Okay. So as we're looking at our bordering states, that's where we would start first and then make it a national level. But the federal government does realize that there is that gap between states that we need to work out.
Let's talk a little bit about consent. How do people worry. I don't necessarily want anybody to be able to see my medical records. What are the protections and what is the process for making sure that my consent is given?
So it's an electronic consent by the patient, although if you have a healthcare proxy or a legal representative, they are allowed to consent for you. But it's truly at your consent. If you say, no, I don't want a facility to see that information, no is no in the state of New York. A patient could say that only in a state of emergency would I want my information accessed. Right. So in that case, then we would allow the provider to what we call break the glass, see the information about the patient only in an emergency.
So I'm here at Southampton, I'm traveling up to Stony Brook, something happens to me. There is an ability for Stony Brook theoretically to get access to my information.
Absolutely.
And let's talk about why this is so important. What's some of the reasons about why accessing this information? And a lot of it, being in the field is very self-evident. I know that if I've got an allergy medication and or an allergic reaction to certain medications, it's probably important that somebody be able to access that information.
We find that people that can benefit the most from this system is those who have several medical conditions, are a patient, know a patient. If your family member goes and travels, this makes it so much easier so that allergy medication that you're on, you're aware of. If you know you're allergic to something, you can make sure that we don't give you that medication. If the patient had an x-ray done, you don't repeat the x-ray, so it could decrease the cost as well.
Even some other tests I know, even laboratory tests. Testing is it's something we should do carefully. One, because it's expensive to the system to keep testing repeatedly, and two, is there is some risk involved with some testing, right?
Absolutely.
Right. And if we have the ability to access certainly medication history or allergies or previous medical records, theoretically, I guess the goal is safer health care.
Absolutely. You want to make sure that you're providing the appropriate health care to a patient. You're not giving them too much medication if they can't have it, as well as too much testing if they've already had that done as well.
Okay, great. I've heard some folks say that I've traveled frequently between Southampton and the city. Is there any way to share my records with my doctor in the city? Could this lead to that and create that ability? Absolutely.
This network that we refer to as the Shiny that we spoke about earlier is the network that would allow that, so that if the patient has a summer home in the Hamptons and lives in the city, that information will be available to their provider when they're in the city, as well as the provider when they're here in the summer.
And I've also heard concerns, well, my doctor's computer system is different from the hospital's computer system or different from a nursing home. Does that matter that the systems are?
Our network is vendor agnostic, meaning we don't care which electronic medical record you have, as long as it is a certified record by the
Center for Health Information Technology?
Yes, thanks. Forgot the acronym there. As long as it's a certified record, then we will connect you to our system.
Okay, and so the system just has to meet certain standards and it can be connected.
Correct.
So one of the descriptions, it's in many ways similar to the phone companies that first evolved in the early 1900s. How do you see that similarity?
They like to call it as a public utility.
Right.
So right now patients are probably not as aware, and that's why we're doing events like this, so that we can make sure that people are aware of it. But in the future, this is where we're headed to. Your banking is online, you're available to have that. Your patient health information should be available as well.
I know it's frustrating. I can go anywhere in the world with my ATM card and I can get cash out. I could be in the middle of Europe or somewhere else and I can still access my bank, but were I traveling and had an accident, it would be very difficult to get my medical records.
Exactly. I traveled out of the country and it took 3 days to get my records translated into English.
Wow, that's a problem. Do you think there's ever a day when we might see it expanded worldwide?
I'm hopeful. We'll see.
Right. What are some of the challenges? What's been some of the hardest things for you to accomplish in terms of building this? It's not, I've learned enough to know it's not nearly as easy. People say, well, why can't all the hospitals and doctors just put their records together and share? Why hasn't that happened up until now?
Technology is a little challenging. We have an open market in the United States, so there are several different vendors that are out there and making sure that they're interoperable. We are trying to get them to speak a language in the information technology world called HL7, Health Level 7, so that there's a standard so that we're sharing the same information. Lab information, for example, what one facility would say is a critical value may be different from a different organization.
Critical value is like if a blood sugar between 8 and 12 or something like that.
Correct.
Okay.
So we want to make sure there's a standard across all facilities, that they have the same level that they would call a critical value.
Okay.
So that piece of that is overwhelming to try to make sure that you have those standards set in place. So a lot of that has taken the time to do that, as well as not every organization had electronic medical records. They had different pieces or parts of it. Normally, hospitals have what we call a stair-step climb. They go live with the doctors documenting, then the nurses documenting. Where an ambulatory center usually goes live all at once, and they just turn it on and every part of the electronic medical record is being documented. So as time has evolved, different organizations have ramped up to have more of their chart electronic. So that's another piece of getting them that information that they now have available in an electronic format. That's of value to make sure we have that shared with the Health Information Network.
Most hospitals, I think, are still in the process of implementing. I know that we at Southampton, our emergency room, many of our outpatient areas, but we're right in the process right now of automating the inpatient record.
And that's a challenge in your own organization.
Right.
So, it takes time.
It does. And money.
Yes.
A lot of money, exactly right. And somebody once said to me, why can't you get a donor to pay for a lot of this? Donors usually don't want to, they'll put their name on the side of a building. We haven't found too many that are willing to put their name on the side of a computer yet, right? So
Yes, exactly.
how difficult is it to sign up for a patient? What is the process? If I want my information accessible, walk me through that.
So at Southampton now, a patient can come to your admitting department when they get registered for their visit, and they'll be asked to sign an electronic consent. It's a signature pad similar to the grocery store that they'll sign for their credit card. And they would sign consent saying that they allow Southampton Hospital to look at their information that's in the reel about them.
Only inpatients or all patients that come to Southampton?
All patients.
So if I come in for laboratory testing, I can go
Absolutely.
through this process also?
I believe you even have medical records consenting patients.
I think we do.
Yes.
Yeah, I think we do.
Quite advanced in our network.
Yeah,
you have everybody consenting.
We like to stay ahead. We are a most wired hospital.
Yes,
know,
you
we
are.
Hear that. Absolutely. How about other information, insurance information or managed care companies? Any participation or thoughts about that at this point?
Right now, insurance companies are not involved. There is conversation at the state level to get them involved. There's some RIOs upstate New York that have insurance companies involved. The way healthcare is provided upstate is quite different than the way it's provided downstate. Upstate patients stay within their communities. They very rarely leave a county that they're in. Where downstate, they cross communities quite often.
Right.
So insurance companies have been involved in the upstate regions because it's been more isolated on how care is treated for it. Down here, it hasn't happened as of yet, but there is conversation about that.
Yeah, there's tremendous movement both up and down Long Island and also to the city and other parts of the country. So at this point, it doesn't include financial information. It's purely clinical information that's shared.
It has the insurance that you registered with. We call it demographic patient information. Your admission, discharge, and transfer information is in the system. But an insurance company doesn't have access to that information at this point. So if the patient came here and was a United Healthcare patient and then was sent to Stony Brook for trauma, if they came and had to go to the trauma center there, they would be able to see that the patient has United. If the patient was in a compromised position and wasn't able to present their insurance card, that information would be there. But United Healthcare wouldn't have access to the information, unless, again, the patient consented and said that they would allow United to look at their information.
So it's only doctors, hospitals, nursing homes at this point. And let's say I had a bad experience with a particular doctor or a particular facility, and I don't want them to see my information anymore. Can I do that?
Yes, you have the right at any time to allow a facility to see the information or deny them to see the information, or only let them see the information in an emergency.
Okay. And how do I know that the information's safe, that people are not, other folks aren't actually accessing this, and protections about the security of that information?
Very common question, very important
Right.
as well. We are regulated by the federal government to make sure that all patient health information, which is referred to as PHI, is kept in a confidential manner. There's Hipaa guidelines, we have security, we have 100% audit of whoever touches your information. As a patient, you have the right at any time to ask who has seen your information, and we can give that as information to you as well as your healthcare provider can. So it is secured in a very different manner than regular information that is out there about you.
One of the things that I would worry a little bit about, my name's not that common, but a lot of people with, if my name were John Smith, how do I make sure that they don't look up the information they find in other John Smith and start treating me and it's the other John Smith, not me?
Right. So our system has what's called a Master Patient Index,
Okay.
or an MPI, which works to match to make sure that the same Bob Challoner is the same Bob Challoner from one organization to another. It uses 14 healthcare criteria to match you. So your name may be Bob or Rob, so it's a percentage of the accuracy of that. But
Okay.
it would use 100% of your social security number if that was something that was provided. But names could be a percentage of it. So it's not specifically has to be typed in as Robert, Bob, Rob.
Okay. Or what if my name changed? I got married and changed my last name. What happens then?
Normally when patients change their name, have any demographic information change, they should tell their healthcare provider. They don't need to tell us directly.
Right.
That information gets updated to us automatically when you change it at your healthcare facility.
Any thought that at some point maybe the patients would be able to access the information themselves, actually go in and see what's on this? And
There has been a lot of discussion about that because it is the information of the patient. It's
Right.
not our information, it's theirs.
Right.
So there's a lot of organizations right now are building what's called a patient portal, and that would give them access. I know you're in the process at Southampton of setting up a patient portal, and most healthcare organizations are doing that as well. And what we are proposing that from those portals, there's a link to our network, so you can see the information from the whole state rather than just from one provider.
any chance that I could download that information someday and take it with me and travel, or?
Absolutely. Again, it's your information,
Right.
so it would be what you would want to do with it, and it gives the power to the patient.
Okay. Doctors' offices, I know we have a number of hospitals. Where are we at in terms of doctors' offices participating in this at this point?
So we've had several providers in Long Island join us
Okay.
this year. I think we're up to over 120 providers have
120
joined
already,
us.
wow.
And by the end of the year, I think that's close to doubling. It's important that ambulatory doctors in the outpatient setting are part of the conversation in terms of a patient's health care. If we only included patients at the hospital, a patient could show up in the emergency room and be a 50-year-old male who has gone for his ambulatory visits, gone for his regular checkups. But if the hospital doesn't know that the patient has been going for their outpatient treatments, they might treat that patient in an emergency situation very differently than they would if they knew that the patient has been going for their regular checkups and had access to their lab results. So ambulatory providers are very important to be part of this conversation, and we're engaging them very much this year to be part of this.
To join in, so
Yes.
we get all of them. Why nursing homes?
85% of a patient's health care happens at the end stages of their life.
Okay.
So to include the whole continuum of care, we really want to make sure that a nursing home is included. A patient could have a rehab visit as well as be admitted to the hospital in the middle of a stay at a nursing home. So you want to make sure that that information is available for nursing homes as well.
And I guess there's a fair amount of movement back and forth then between nursing homes and hospitals, so certainly
Yes.
would make the record easier to obtain. Somebody told me the idea of sharing information, having it in a central place can be difficult, potentially security, but I can also see the opposite. If we've got a paper record and that paper record's inadvertently destroyed, you've lost everything, and the chances for
Exactly.
backing up and maintaining the information are probably easier.
It is much easier.
Right.
So there's a backup of the system, so if something did happen to the network, there's a backup of it, but if you don't have a backup of your paper record, that could be quite a
It's
challenge.
gone, right, exactly. Denise, one of the concerns I was asked once was, so I went and I had a lab test, and then I had an issue, but it resolved, and then 3 months later I got a new lab test. Is that updated automatically in the system? Is all of that?
Yes. We try to make, when you say about sharing a patient's information,
Right.
one patient can have an awful lot of information, and we refer to that as data. You want to make the data information. You want to make it usable for the provider. So a lab test that you had in the past 3 months would be in the system and be relevant to the provider. A lab test you had maybe 6 years ago, not so relevant. Still accessible in the system, but not something that you want the provider to see when they're in that emergency room situation to see the information about you.
Okay. Tough question. I'm a patient. I want my information. Do I have to pay for this?
No.
Okay. No charge to the
No
patient?
charge to the patient.
Okay. Providers, I know, and there is some. Where is most of the money coming from to set up these networks?
So right now, many of the providers in our network support the network. They see the value of it. They know that in the long run that it's going to save a lot of money for their organization as well as be better care for the patient. So they're the ones that, at this point in our network, who are supporting the eHealth network.
And any worries about viruses, or I'm not talking about medical viruses now, computer viruses, and I'm sure protocols must be in place to really protect the integrity of the data and as you've said already, the security.
Yes, there's constant checks on the system that are automatic, that alert you if there is anything that's in the system. We constantly train people about breach to make sure that they understand what a breach is, how confidential the information is, how you need to make sure that you're maintaining yourself and making sure you log out of your system so that the information is not accessible to anyone else.
I may go to a laboratory that's not part of a hospital, and a private lab or private radiology facility. Is there any chance my information could be shared from that as well?
We are having conversations with outside labs as well as outside radiology centers. Okay. Again, any point along your healthcare pattern that you receive care, we want to make sure they're included. Your home care agency, your pharmacy.
Pharmacies too at some point? Yeah.
Absolutely, yes, because we need to show the whole picture of what's happening to the patient so that the provider can make a well-informed decision.
How long do you think it'll be before all of this is in place?
I'm hopeful and optimistic, but a couple of years down the line, I'm sure, because we have to get, the public engaged to understand and to be understanding of what we're doing and the rationale for why we're doing it. This information is only used for patient care. It is not used for marketing. It is not used for anything else than to help improve your quality of care.
So not accessible to fundraisers, marketing, private companies that may want to. What about research? Can it be used for research?
There's conversations right now, no, but there is conversations about that. There's also conversations about using what we call de-identified data. So it's information about you, but it doesn't have your name on it, so that we can do what's called population health and look at diabetic patients as a whole, how their treatment is going for men of a certain age or women of a certain age. And that thought is down the line, but at this point it hasn't been used for that.
Something was asked me the other day, and this is a very timely question with some of the concerns about government monitoring of phone data. Not happening today, I would assume, that the government's not monitoring our health data, and most of this data, I understand, is provider to provider, so it really isn't.
It is provider to provider. There is some information that organizations are required to give to the public health department in terms of viruses that are that occur at an organization, or if someone has a disease that needs to be tracked. But otherwise, no, they do epidemiology studies for cancer patients, but the information is not shared through our network at that point.
And the public health data that's shared is what's always been shared?
Always been shared,
Incidences
correctly.
of tuberculosis
Absolutely.
or communicable diseases that could be a public health threat.
Right.
So no active engagement with the government oversight or viewing of the data at this point?
No, there's been conversations of that as well. I sit on the state the policy committee for the state, and there's always discussions and making sure that the information is secure and that the right people have access to it. And we have what we call user-based roles, so that we make sure that a nurse could have different access than a physician could have access to, as well as a clerk. Clerical staff that you'd be consenting to at an organization don't have access to your clinical information. They just have access to your demographic information, which is what you provide them when you register anyway.
Good point. So if I walked into an emergency room and the ER clerk couldn't pull up my medical history from my doctor's office. So.
Exactly.
Let's talk a little bit about just maybe an example of how you think this technology may save a life.
A perfect example is if a person on Long Island was traveling to another part of the island for a holiday, let's say, and God forbid there was an accident, they end up in the emergency room, When they get to the emergency room, if they're part of this network, they'll be able to see, the provider will be able to see what medications the patient is on, what allergies they have, so they can treat them appropriately. Because if the patient is in an unconscious state, you wouldn't know that information. Many times the family is nervous and it's a traumatic experience. So this allows that information to be available and to help save that patient's life.
Mm-hmm. So often patients come in, they aren't in a position to answer questions. They may be unconscious or
exactly,
or in a state where they just can't. And most of the medications, I can't even remember the names of most of the medications. I'm sure that can be a challenge. How would the provider even know to look for this information on a patient? Let's say Bob Challoner showed up in the ER, I'm unconscious, and would they just have to scan through millions of records to find me, or how would that work?
So the way we're building it with our partner facilities is that while you're in the electronic medical record of Southampton, a button appears on the side that says eHealth Network.
Okay.
And the provider can see and click that button and see if there's information in it. We look to make sure that it's the minimal amount of keystrokes and clicks of a mouse that a provider has to go through in order to get to this information, especially in a timely emergency. You want to make sure that it's quick and easy for them to get to.
This is the name or nickname I've heard for it is the blue button, right? That they can.
The blue button has been started as the federal government to be able to have that. It's our version of the blue button.
Okay.
It's not all the information across the state, as we mentioned, but it's the beginning of the blue button.
Okay, and if that would automatically appear, I guess, on my record, so the provider wouldn't have to guess. They would just.
Yes.
And it would be. I'm sure it's something that's going to be built. Over time, it would accumulate.
Healthcare is constantly progressing, especially in the state of New York, so it's constantly evolving, and we're growing with it.
Right. I know that there are some interesting new opportunities that are being developed also. The state is trying to incubate some new companies, frankly, to allow us to use data better, smarter, more quickly in healthcare too. And can you talk about that a little bit?
Sure. The organization we spoke about, the New York eHealth Collaborative, has started what they refer to as the Accelerator Program, where they have new electronic gurus, if you will, in this space, as well as venture capitalists who are willing to fund this, and healthcare organizations like yourself. Mm-hmm. With the three of them partnering together to say, this is the challenge I have in a healthcare facility, and the vendor comes and builds the solution, and the venture capitalist supports the development of it. And with the three together helping to improve the patient's care and making sure that those challenges that we have in terms of trying to identify medication reconciliation issues about a patient, or identifying any type of impediment that we have, making sure that the patient's care is done, these three organizations work together to come up with that solution.
So all of this is toward developing, I guess, better information systems, better electronic record-keeping systems, which are still pretty primitive in healthcare. We're a little behind most industries, wouldn't you agree?
Absolutely. And New York, they do say, is a leader in this, but it's all about making sure that the data is information and usable for the providers.
And one last question for you: where do you see Long Island eventually, or how do you see Long Island? Are we ahead of the curve at this point, do you think?
I think we are. I think that when I think about what all the other states are doing, New York and Long Island are pretty ahead of the game. We have engaged many providers. Right now, our major concern is making sure we educate the patients to make sure they are well aware of what we're doing and that it is in a secure manner and it is for their best interest.
Wonderful. Well, Denise, thank you so much for your time today and all the good work that you're doing. I know that this is a very technical topic, but it's something that many people aren't even aware of. And I think the ability to share that clinical information quickly and timely ultimately will be a lifesaver for many people. So thank you for all your good work.
Thank you for having me.
And I'd like to thank all of you for tuning in today and watching. I'd like to thank our friends at CTV for producing and airing this show in Southampton. And I'd like to thank our friends over at LTV in East Hampton for showing to our East Hampton communities. If you have any questions or concerns or would like any additional information or just help navigating the healthcare system on the East End, please give my office a call at 631-726-8555. Thank you very much and good health, everyone.